Thank you, Dr. Simonstedt. We have basically here heard about two procedures, one for impingement, where there's an incongruency between the ball and the socket, and what surgery accomplishes is basically making the joint congruent again, hopefully preventing further arthritis or any arthritis to develop. And the second procedure, resurfacing, where only the ball of the hip joint is capped and much less bone is resected as in a conventional total joint replacement. A big concern from a lot of patients going into surgery is anesthesia and about the pain management or the pain level after anesthesia, after the postoperative days. And Dr. Conterato, what is your approach to that?
Well, thank you, Dr. Jacobson. Certainly, I concur with you completely. Patients have a great concern about the amount of pain they're going to experience following these types of procedures, and it can actually be an obstacle to them considering undertaking these options early enough so that they can preserve the joint. Pain relief is rated one of the top concerns the patients have coming into major orthopedic procedures. Unfortunately, at St. Joseph's Hospital Marshfield Clinic, we employ advanced techniques of regional anesthesia or nerve block anesthesia to provide excellent pain relief for these patients in the postoperative period. The traditional approach to hip surgery and total joint surgery in general that had been taken on in the past was to use opioid or narcotic-based regimens of pain relief. The problem with these is that they have accompanying many side effects that are detrimental to the overall well-being of the patient in hospital. Certainly, when significant amounts of narcotics are used, which is often necessary for this type of surgery, sedation is a major side effect. In addition, the sedation can be so profound that respiratory depression ensues, and we have to intervene to try and help the person breathe at an adequate level. Nausea is an extremely common side effect of narcotic medications and is one of the things that patients actually fear the most with surgery postoperatively. Additionally, constipation, urinary retention are very common. And one of the more important things also is that the pain is not well covered for what we call evoked pain. That is to say, the type of pain that occurs with movement of the joint and when the patient is first getting ambulatory or engaging in physical therapy in the first several days postoperatively. There are several different nerve block options then that we have employed as alternatives to pure narcotic-based regimens that enable us to treat the pain. Initially, what had been used in the past was what's called an epidural catheter infusion, which is a small tube about the size of a piece of fishing line that is inserted adjacent to the spinal cord and coats the spinal cord and exiting nerves that go to the hip with local anesthetic and often with small doses of narcotic medication. The problem with this is also a very vascular area with fragile veins coursing through it, and the more recent approach to the perioperative management of these patients is to be very aggressive about preventing post-operative deep venous thrombosis or blood clot in the legs. As a result of that, this also puts the area where we have gone in with the epidural catheter at risk of bleeding around the spinal cord, and the outcome can be disastrous in terms of injury to the spinal cord, numbness, paralysis, and other neurologic deficits that occur. Additionally, these patients have urinary retention and are not able to really do much in the way of walking with crutches as a result of having both legs numbed up. What had been tried in the past as an alternative to that is what's called an epidural single-shot injection, where instead of putting any significant amount of local anesthetic in, through a single injection in the epidural space, a long-acting preparation of narcotic called Depo-Dur was placed around the spinal cord to coat these nerves and give them pain relief. The problem is that the same narcotic-related side effects that we had discussed with the intravenous approach are also experienced with the epidural single-shot approach. And again, this has not been a very satisfactory technique and is associated with a lot of side effects as people get older. The nerves that constitute the lumbar plexus, which is the major nerves going to the hip joint, are the second, third, and fourth lumbar nerves. The femoral nerve constitutes L2, 3, and 4, but unfortunately it is a little bit beyond where the nerves start to branch off into the hip joint. A continuous femoral nerve block had been employed in the past, but the coverage was less than satisfactory. By coming closer to the spinal cord area, but not actually being in the spinal column, we can place a small catheter similar to an epidural catheter in the plexus of nerves buried in the psoas muscle as they course from the spinal cord or vertebral column area to the hip joint. And this is the major technique that we employ at St. Joseph's Hospital Marshfield Clinic. Multiple prospective studies have been done looking at this, as well as what we call meta-analyses. And a meta-analysis is where we compile all the data from multiple single studies and get much larger numbers to be more statistically relevant. And on a consistent basis, there's been a clear advantage of continuous lumbar plexus blocks in terms of the quality of analgesia, lower incidence of side effects, and attaining the physical therapy goals that we would like to achieve in the first several postoperative days. The analgesia that we see with this clearly is better than that we achieve with epidural catheters and with the femoral nerve blocks, and there is a lesser degree of motor block than with those other two techniques. So again, the patient is able to be up crutch walking and doing some partial weight bearing in the first couple days, as well as being able to tolerate what we call evoked movements with the hip joint, and their pain with movement is much less. It is also compatible with the more aggressive modalities of perioperative DVT prophylaxis that we use, and we can safely have that catheter placed in the psoas muscle without concerns about ongoing nerve damage like we did in the epidural space. So this constitutes a pivotal point of or component of a multimodal analgesic regimen that includes running a lumbar plexus catheter infusion for the first 48 hours, as well as scheduled gabapentin, acetaminophen, and as needed doses of narcotics orally. This is a diagram demonstrating how we approach this. Typically what happens is the patient is sedated so that they are comfortable and tolerate this procedure very comfortably. The area is prepped with a sterile solution and then draped off. And after anesthetizing the overlying skin where we're going to approach it, what is called a stimulating catheter needle is inserted about 4 centimeters lateral to the middle of the vertebral column. Those 3 circles you see, or ovals you see in the middle, represent the midline spine, and we're about 4 centimeters to the side on the operative side of the spine, entering into the psoas muscle. We pass a very small, imperceptible amount of electrical current on an intermittent basis through this needle, and when we come in close proximity to the nerves of the lumbar plexus, we actually evoke the motor responses that those nerves convey. That is to say, we will see twitching out of the calf or thigh muscles, demonstrating that we are in the plexus area that we want to place the catheter in. This is a cartoon demonstrating the location of the lumbar plexus nerves. And so we have the lateral femoral, cutaneous, femoral, and obturator nerves. Dr. Kenny is demonstrating that right there. And what you see is there's a fascial plane or a compartment within that psoas muscle wherein the lumbar plexus runs, and we're able to pass a catheter and run a continuous infusion. This is just a dissection where much of the psoas muscle has been peeled off, demonstrating that all these nerves of the lumbar plexus run within the same plane, so that if we can get a catheter into that proper plane, all these nerves will be bathed with local anesthetic. Again, this is just another illustration of the same fact. Dr. Kenny is demonstrating the small catheter coursing through the subcutaneous tissue and muscle to lie within that fascial plane where the lumbar plexus runs, and we have injected a small amount of X-ray contrast dye that highlights the entire lumbar plexus, showing that even small amounts of local anesthetic give us wide coverage of the nerves going to the hip joint. One of the benefits to this is that the patient is now able to engage in physical therapy and is quite comfortable in the recovery room, so that we're able to progress with a much more rapid and efficient therapy for the patient postoperatively.